Hey, good afternoon, everybody, and welcome to our fourth in our series of our Nursing Reimagined webinars. My name is Helen Aviard, and I'm an Associate Professor at Oxford Brookes University, and I'm Programme Lead for the Professional Doctorate in Nursing and Midwifery. It's really good to see everybody here. In this webinar, we showcase the work of our doctoral students, and today we are very pleased to welcome Dr. Carol Forde-Johnston and Dr. Lian Lee, who have both fairly recently finished their doctorates with us. Carol undertaking a PhD, and Lian was on the professional doctorate programme. Both have looked at the impact of technology and the role that this has in shaping communication. And some of the findings that they have, some of them really did surprise us all. I'm very pleased also to introduce Dr. Claire Merriman, who will be chairing the session this afternoon. Carol, thank you very much for coming to share your experiences this afternoon, and over to you.
Thank you, Helen. My understanding is Sophie's going to do my slides. Yeah, okay. So thank you. I'm just going to put my timer on to make sure I've got 15 minutes to present. So thank you for inviting me to speak today. As Helen said, I have recently completed a PhD at Oxford Brookes University, and I work at the Oxford University Hospitals NHS Foundation Trust as a recruitment and retention nurse lead. I'm going to briefly discuss the findings around my research study and the implications for nursing practice, education and research. So hopefully we can have an interesting discussion today, and we're really happy to answer any of your questions. My study explored nurse-patient interactions in acute hospital settings when electronic patient record EPR systems are used. And as I said, I did a PhD at Oxford Brookes University, which I really enjoyed. I had fantastic support. So I'm really happy to connect with any of you who are thinking about doing a PhD or are currently on a PhD about my experience of being a student. So I'm sure Sophie will share our details after. Because today's session's really discussing the findings more than going through all the methods of my study, if you are interested in reading my full thesis, it's available on open access under Oxford Brookes University Radar, and Sophie will share the link after. And I just wanted to acknowledge my PhD supervisors, Dr. Helen Aviard, Dr. Dan Butcher, and Dr. Ginny Mintz, who were amazing support during my PhD. So looking at my research question and aims. So the question was, what is the quality of nurse-patient interactions when nurses use an electronic patient record system in an acute care hospital setting? I explored nurses' use of electronic patient record systems in 4 acute hospital ward settings. Another aim was to identify how EPR influences the quality of nurse-patient interactions when nurses use the EPR system. And also, an overall aim was to contribute to the developing evidence base relating to the effect of digital technology on nurse-patient interactions. Just a little bit of background. I conducted an integrative review with the support of my amazing supervisors, and that explored the impact of electronic records on the quality of interactions. And there's a lack of research in this area, so do check out that paper. Again, we can send that on a link. What you'll find if you do review literature in this area is the majority of papers evaluate the deployment of electronic record systems, pre-post deployment, for example, and espouse the benefits and the challenges of using those systems. There's also empirical studies showing that EPR assures patient safety and clinical outcomes, but there's limited empirical data on the nurse-patient interactions and communication when nurses use technology, and that includes electronic patient records. The research in the UK, there was 2 studies that looked at primary care. In primary care, looked at nurse-patient communication, but the majority were Australian or US studies that have looked at this area. So it was a unique area. So looking at the mixed methods in this study, I conducted 16 observations using a quality of interaction schedule tool, validated tool by McLean et al. To assess the quality of those interactions and to code those interactions. And I also timed the duration of nurse-patient interactions, and I used observational field notes. I also conducted 16 semi-structured audio recorded patient interviews to explore patients' perceptions of the quality of nurse-patient interactions, and 16 semi-structured audio recorded nurse interviews to explore nurses' perceptions. Next slide, please. So you'll see here a picture of a computer on wheels, and the majority of UK hospital trusts use computers on wheels or static computers. In the trust where I conducted my research, the nurses would wheel the computer on wheels into a bay with the patient, with 4 patients, or into a side room. And all of the ward nurses in this study used computers on wheels. As I said, the majority of UK hospitals will use this system, but you will see sometimes specialist nurses using iPads, but the large majority will use this system. Next slide, please. So looking at my key findings, firstly, nurse-patient interactions were observed to lack social, open, reciprocal, two-way and face-to-face communication. Nurse-patient communication was screen-driven, task-orientated and formulaic for the majority of those observations. Only a few experienced nurses asked open questions. How are you? Is there anything else I can do for you, for example? Instead, the majority of nurses were focused on completing electronic checklists in the presence of the patient. All the nurses completed their electronic patient records on the computer in the presence of the patient rather than outside the room. They also used a rounding approach that was observed. So patient encounters were triggered by an alert on the EPR, or the patient's medications were due. There was a lack of spontaneous contact with the patient. It was driven by this rounding approach and those alerts on the system. The second key finding was that cumbersome computer systems monopolized nurses' time and attention, and they impeded face-to-face communication. You can see how bulky the system is. And the nurses that some experienced nurses would move that bulky system out of the way to be able to observe the patient, but the majority of nurses didn't, and that cumbersome system caused a barrier to face-to-face communication. Most nurses also found and described computer issues that impacted nurses' time. So delayed logins, not enough computers, too many electronic gateways to navigate, which took time. And as I said, the cumbersome computers created this barrier, so you had to move the computer to see the patient. The third key finding was that nurses' use of electronic scripts fostered a task-orientated agenda. And there was positives to this and challenges. The positives were that majority of nurses and patients felt that EPR scripts had benefits such as assuring safe care. Care was evidence-based, it was delivered on time. So, for example, patients really wanted their medications on time, and many of them mentioned that the EPR system meant that the patient's medications were given on time. Nurses felt assured and confident that the care they were giving was right as well, was evidence-based and given at the correct time. However, the majority of nurses also felt that conversations, nurse-patient conversations, were dominated by medical aspects of care, and rather than psychosocial aspects of care, as their focus was completing these checklists. Next slide, please. Hi, Sophie. Next slide. Oh, thank you. So looking at the observations, so I timed the nurse-patient interactions and also the amount of time that nurses were spent on a computer and off a computer in the presence of patients during those nurse-patient interactions. Interestingly, nurses spent on average 61% of the total observation time on the computer when in the presence of the patient. Over half of nurses spent the majority of their time using EPR with their back to the patient. It was 66% of the total time with their back to the patient in the presence of the patient. 9 nurses were also observed conversing with patients with their back to the patient. Next slide, please. So I just picked up on a few interesting narrative from the study. So one nurse participant, for example, said 30 questions in 10 minutes, one after the other. It's not real communication. It's not natural. It's like sometimes we're not having a proper conversation as we're focused on completing EPR checklists. And this is quite, this is similar to a lot of other nurses that were describing how the communication was taking place and how it felt to them during that nurse-patient interaction. Next slide, please. Another patient said, there's 3 of us in this relationship, the patient, the computer, and me. And again, went on to describe how this impacted their care, person-centered care, and the relational aspects of care. Next slide, please. So as part of my conclusion was that there's this tripartite relationship between the patient, the nurse, and that technology that's being used. And that's something that as nurses, we really need to think about in the future. How digital technology, be it EPR, or any other type of technology that you're using in the presence of a patient, how that is affecting that relationship, that therapeutic relationship and person-centered communication and aspects of care. Next slide, please. So overall, my conclusions showed that there was positives. EPR assured safe medical care. It increased nurses' confidence as well. The second key conclusion is that nurses' EPR use hindered person-centered care and shared goal planning. Digitalisation has clear safety benefits, but has the potential to dehumanize that therapeutic relationship between a nurse and patient that requires a compassionate, two-way, open, person-centered approach. Person-centered care fundamentally relies on nurses actively bridging the gap between patient care and digital systems. Effective, open, two-way communication is critical for patient participation, shared decision making, and communication skills are just as important as digital skills. So what are the future implications for our profession? Hopefully we can discuss some of these implications as part of this webinar. But what are the implications relating that there's this inadvertent shift towards task-based interactions and care and medical focus on care at the expense of patient-centered communication? And what are the implications and what can we look at in practice research and education? And I've just put a few thoughts here. So integrating more open and person-centered narrative into electronic patient record scripts, for example. There's some research out there where researchers have asked patients to write some open narrative to go on their electronic patient records before they go into hospital, for example. So they have access to be able to do that. There's other research, people that have done studies whereby they have, the nurse has got open questions as part of the admission documentation and care plans, rather than just these didactic yes/no answers or reading off scripts, that we have more open-centered questions, not just checklists on electronic patient records. So that's something we could potentially discuss. Less obtrusive technology and more user-friendly systems is something that really came out of my study. And that would enable nurses to have more time for communication. Nurses still need to introduce themselves, ask open questions, explain what they're doing. But if they're focused on mandatory checklists and don't have enough time, they are going to focus on completing those alerts because they don't want to get into trouble and have the alerts turn red. So there's an aspect of how much time nurses have got to balance the relational aspects of care with completing these checklists. Education, increasing awareness to promote effective communication is really important as nurse educators when we use technology. And so part of that is that when we train nurses up to use technology, are we also talking about the communication aspects? Should communication be part of proficiencies that when you're looking at student nurses, for example, are we just saying they've got to be able to technically use the technology? Actually, there's a big part of managing that technology and balancing your communication, potentially using simulations in universities. To enable students to be able to balance the technology, and additional support for junior staff, students, and international nurses who are not used to those systems. What came out of my research was that experienced nurses, especially nurses trained before technology was brought in, were much more able to balance the technology, come out from the computer, openly communicate. If you haven't used an EPR system before, and many of our international nurses hadn't used EPR systems, they were focusing on the computer. It's taking them longer. So education on qualification, on preceptorship programs, we need to look at assessing individuals' learning needs. Has this person ever seen EPR before? Do they need more time to learn how to, supernumerary time to be able to use these systems? And then lastly, research, examining nurses, EPR use, its impact on nurse-patient interactions. I obviously looked at UK hospitals, but we should be looking at community. There's a lot more iPad use in community. Learning disability, mental health. Would the findings be similar or not? Also, I think a really good piece of research would be looking at the amount of time nurses are spending on digital technology, time spent on and off computers that could feed into nurse staffing tools. Lots of our nurse staffing tools were probably created before we had such large, wide use of technology. Anecdotally, I trained in the 1980s, and I do not remember spending 60%, over 60% of my time on documentation. It was always we spent a lot of time on documentation. But with technology, are we spending more time than we did in the past? Which is what my research was showing, that we were spending this vast amount of time in the presence of patients on technology. And so it'd be really interesting to look at examining that, the time element being spent. Last slide, please. So questions for our profession. Are we happy for a systems-based approach in nursing to dominate as more technology is integrated with less face-to-face care? If we don't conduct more research in this area, will the essence of nursing be lost, such as relational care and a person-centered approach to care? Thank you for listening.
Thank you very much, Carol. We're going to save obviously questions for Carol to the end. We'd now really like to invite Lian to tell us about your project, and then we'll pick up the parallels.
Thank
Thank
you.
you.
I will share my slides. Okay. Yeah. So I think, Carol, very interesting discussions from your presentations. I think to come to my studies is very much of which focusing around the advanced technology, which is surgical robotic. Following EPR, as part of the surgical pathway, as you say, EPR is one of the additional gadget added to our nursing care in a surgical setting. Now, robotic surgery, it will be additional tools which perioperative nursing will need to consider. And how we need to reimagine nursing in this complex setting, especially with the NHS 10 years health plan. And in 2026, this year, we are having an exponential uptake of surgical robot in our practice. And my research started 5 years ago. 5 years ago. With a focus on exploring what's the communications experiences nurses encounter in this complex, dynamic environment in robotic assisted surgery. In short, we call RAS. My study is a qualitative studies using a reflexive thematic analysis. I will not go into details of the methods I used and also any other further in-depth discussions. Today, I will present my finding. And before I proceed, I'd like to acknowledge my appreciations to my supervisors, Dr. Su Suk, Dr. Helen Aviat, and Dr. Catherine Greenway for their support throughout my course of professional doctorate study. Let me share with you why professional doctorate. As you know, Carol's from PhD background. I chosen professional doctorate because I felt that as a very busy clinical practitioner, heavily focused in practice as well as in the hospital setting. And professional doctorate really given me the opportunity to conduct the part-time research while focusing on practice. At the same time, I am actually solving the real world problem through empirical studies. And hence, I have had numerous conversations with the expert, and I've decided, well, professional doctorate, that's a path for me to raise the nurse's voice in a platform that I felt is the right time for the nurses in this very medic dominant environment to have their voices heard, and also the key role nurses in a complex surgical environment to fit in with today's webinar title, Reimagine Nursing in the Advanced Digital World. So this slide is showing you the shifting dynamics in surgery in the perioperative nursing setting. For those of you not working in the operating theater, you can see that the left-hand top open surgery. You can see all the surgical team, the nurses, the scrub nurse, the surgeons, and everyone looking into the same operative field. As the year progresses, over 20 years ago, 2 decades ago, laparoscopic surgery introduced. Yes, everyone, instead of looking into the abdomen, everyone looking into the screen. But everyone still share the same image. Everybody still in a very close proximity. Look at the right side, robotic assisted surgery. In the center of the room, there is this white giant robotic arm, and with the surgeon separated away from the surgical team and separated away from the patients. And now the patients with the robotic arm and the instruments attached. Hence, the nurses and the assistant at the bedside played a key role in ensuring the patient safety as well as communications being relayed safely. I will share with you a quick video showing the actual robotic surgery. And before that, I like to introduce to you, there are different type of robotic surgery in the current market. The robot that you're looking at with the 4 arms, and these are soft tissue robotic tools. There are other robots which are designed for spine surgery and other surgery, but my research really focused on the soft tissue robotic surgery, but there are relevant transferable findings to other settings. So this is in a environments that a surgical robot occur, and you could see the color from the robotic arm. And these are very important key indicators the nurses at the bedside, they need to understand. The nurses looking at the screen, a lot of images, and the noises from the robot. But the surgeon is not at the side of the patients, and instead, the surgeon is actually sitting away here at the console. And the surgeon is speaking to the bedside assistant and the nurses through the console. So the communications with the change of physical dynamic is a added complexity to the actual surgery. So you could see the arm of the robot is actually moving, and that movement is mimic the surgeon's hand. So it is a setting that we know is one of which is a problem in real life for one who hasn't got the experience. And communication breakdown in RAS, in short, has a profound impact to the quality of patient care as well as the nurse practice. And robotic surgery, although it enhances precision and patient recovery, but it poses challenges to the team from a multi-professional perspective in the operating room, because now there's this added robot on top of everything else that nurses need to ensure that they are vigilant of. And additionally, the lack of empirical evidence addressing these contemporary issues in practice is of significant. Hence, I decided to ask the questions and to explore what are the nurses or experiences in the robotic surgery which enhance or hinder their practice and care outcome. And my research finding has found the factors. They are being grouped into 4 key domains from my finding: the person, the robot, the environment, and the system. And very interesting, my research found the juxtapositions of communication in this environment. From the person perspective, everyone needs to have familiarity in this setting, the knowledge, the skills, but now it's not just about technical skills. The relational, the communications, understanding of all the signals. What's the robot saying? And now come to robot. The robot, the surgical robot, although it provides a 3D images and also additional we call slave monitors. Yes, it allows the team in the OR to have a better perspective of what the surgeon they are actually seeing. However, too much information is not helpful. The participants, they experienced a mental overload. They were overwhelmed with all the informations on the screen from the environment, especially assisting in dark. And the environment is one of which is so critical. Sometimes silence is very crucial. In this very noisy background, with everyone separated in a dim room, the nurses at the bedside, at the side of the patients, have to listen to every single noises from the machines, from the people, from the surgeon. However, silence has been found as a key information. Is not about silence without information. Silence itself, it indicates danger. It could indicate attentions. It could indicate some things that everyone needs to pay attention to. Now, without the knowledge in this complex setting, people will say silent, maybe everything is fine. But to a knowledgeable practitioner, nurses at the side of the surgeon, at the side of the patients, silence has got deep meaning behind. In terms of system, we are referring to currently their lack of collective system that enable a multi-professional training to enhance the communication aspect in this complex environment. Yes, there are simulations, there are simulations training, there are training specific in robotic assisted surgery, but nonetheless, from relational perspective, my research has found that it is paramount on top of everything else. The thematic analysis have found 4 key themes. As you can see, this is a busy slide. I purposely share this busy slide. There are 4 themes. Theme 1 is telling you nurses in this complex environment in darkness, they need to triangulate multiple sources of information. Silence perceived as critical but can be problematic. And nurses, they are actually sitting in an environment, in a setting, in a positions that they are navigating around the room. They are navigating and they have the helicopter view to overcome communication barriers. Surgeon at the console away from the patients and nurses at the side of the patient. They have an overview of what happened in the operating room as well as what happens to the robot and also what are the key informations that she needs to pick pick up and also share with the surgeon. Trusting relationship, I can't emphasize more. We need to empower nurses to speak up, but with trusting relationship in this setting is key and paramount. And the 9 accompanied sub-themes will then feed into this 4 main theme. In the center of this picture, you could see the 3 circle, the micro, meso, and macro communication model, which is the finding that I have concluded in my discussion. This equal communication space has never been discussed. The nurses who assist in this robotic assisted surgery in this critical complex setting, they are situated in a meso space that they could navigate around the whole complex communications interactions in these dynamics. And the macro environment is very key between the surgeon and the robot and the nurse, who could either be a surgeon assistant or the scrub practitioner. Whereas the macro level, the communication will be the overall in the operating room that the surgeon would have no understanding exactly what's happened, but the nurse is sitting at the meso level and this eco complex space, she is the driver of safety in this environment. And you can see I have put silent leadership at the background. Why? This is something unexpectedly. Everyone in the study, they share the importance of silent. The dynamic in this environment shifted, especially in leadership. Nurses who are assisting in robotic assisted surgery, they are and they have been in a leadership role. They are leading the communications, they are leading every aspect of interactions in this complex setting. And therefore, silent leadership is one of which that unexpectedly shared among all the findings and key on top of the eco communication system, which I have developed from the findings. So this is the last slide I just like to share with you. Since it is a reflexive thematic analysis, I have found that the reflections to poetic writing is key and fundamental in our current empirical world, whereby data, especially when AI integrations is key in the future surgical robots, and AI is driving data. AI will be our friends as part of the NHS 10 years plan, but we are humans, will lead the AI world. But what's intrinsic to us in humans is our intelligence, that our relationals and our thinking processes. Thank you. I'll hand it back to you now, Claire.
Thank you very much, both Carol and Lian. They were really interesting talks. And although I've heard you discuss your findings a number of times, each time I've picked up something different. Now, we have got some questions in the chat. Please do continue to add your questions to the chat. So I'll go to the one, first of all, this is probably for you, Carol, because of it came up very early. But the question is, did you feel that do patients feel neglected while nurses are utilising electronic patient records? I know that your study didn't specifically look at that, but what's your perspective on that?
Yeah, when we looked at, it was really interesting because when you compared nurse perceptions and patient perceptions, the nurses were probably a lot more negative about electronic patient records becoming this barrier, having too much time being spent on them because they use the electronic patient records. Whereas patients were acutely ill, lots of them were about to be discharged, and the research was carried out on cardiac, oncology, medical ward and an acute surgical ward. So because they were sort of going home they weren't deteriorating. They were really grateful that their physical needs had been met, and they very much perceived the EPR as making sure they got their medication on time. But there were several patients that felt that it took the nurse too long, that they had to go and hunt and find computers, and that they were focused on the computer more than them. So there were some. So overall, comparing nurse-patient perceptions, nurses was more negative than patients, but patients, there were several patients that mentioned about nurses spending too much time versus talking to them. But they were really sympathetic because they saw it that the nurse didn't have enough time. So
Yeah,
it's
it's
a really
really
good
interesting,
question.
isn't it?
Yeah, it's
Rather than thinking about how the nurse could still be able to talk to them and do their role.
yeah,
So
yeah.
really interesting
Yeah,
debate.
I think it'd be really
Um,
good to do on a war on in community though, or in areas that haven't got the patients haven't got such acute care needs, and in different settings. I think it would be really fascinating to see if it was sort of comparative.
Yeah, absolutely. The next one's for you as well, Carol, and it's from I think a very old friend of ours, Jackie Hunt.
Oh, hi,
The
Jackie.
people that we worked with. I'm hoping it's the same Jackie. It might be a different Jackie. I may be putting two and two together and making four here. I mean 5 or 6 or whatever. So she wanted to understand a little bit more. You mentioned that there was a difference between you saw a difference between the more experienced nurses and the more junior nurses.
Mm.
So she was wanting to know about the specific differences between how experienced and non-experienced nurses use the ER, because Jackie actually is in a community setting now, is that, you can see things differently. So what was your findings related to that?
Yeah, I mean it's really interesting because I only interviewed 16 nurses, so it's quite a small group really. But out of those nurses and also combining my observations, what I saw was that experienced nurses were able to manage the computer, that bulky computer, and get on the system quicker. But they also maneuvered the computer out of the way and they put more onus on two-way communication. So there was two aspects really. If they're more experienced, they're more likely to be able to use the computer and not it won't take them as much time on a computer. But there was also an aspect where one or two of them mentioned that they had trained before there was computers, and one of them actually said, "My focus is the patient, not the computer," for example. So there's sort of nurses that are experienced, really sort of from a different generation, from 80s and 90s, before we had computers, were taught to do care plans with the patient, to have that. I'm not saying that more junior nurses aren't, but if you were a nurse before there was computers, you might put more onus on that. I don't know. So I'm not presuming or making assumptions, but it was something that did come out of the research really. So it'd be good to do more.
That'd be really interesting to
Yeah,
explore in more depth, wouldn't it, Carol,
yeah,
around that? Because of, in a way, you would think maybe it'd be the opposite way around, because those of us
yeah,
of the older generation aren't
yeah,
used to those, whereas obviously younger generation have been brought up, have not known anything different,
yeah,
in
yeah,
those types of things. So some really interesting points, and
yeah,
maybe a bit more deep study on that type of thing would be something.
yeah.
Thank you, Lian. This one for you. So this is the question that I'm sure we all get asked quite often. Do you think at any point would AI be able to replace human nurses and doctors in the future?
AI will be our friend. It's just like the NHS 10 years plan encouragement. We need to treat AI as nurses and doctors' friend. AI will never replace us. And AI will be our power to drive our initiative and to drive our future healthcare. But we human beings, as is it now, is not replaceable, because we have a lot of relational aspect which is still not being captured in large data. Hence, my study focused on qualitative. Why? because qualitative data is one of which is so meaningful that it's captured everyone's perspective. Although everybody working in the same setting, the responses are so different, especially we human, we have these intuitions and intuitive critical thinking and critical responses to any situations is one of which unique to us.
Great, thanks, Lian. So I think what you're saying is that we need to make AI our friend, but not be reliant on it, and actually use it to, I think, in a way, to the healthcare is changing, isn't it? Greatly, and we need to embrace it.
Yes.
And that's what Samantha's just put in the actually. We need to embrace it and use it to our advantage, and actually help us. Again, linking to what Carol's study found is that people are saying that it's taking too long. I don't know how many of you I'm going to open up here now, been watching The Pit, the new medical series that's coming from America. It's really interesting because it's talking about AI and technology, and there's a new consultant in AE, and he's using the new, like we've got it here, the NHS app that automatically writes your notes and so forth. And again, it's not perfect, but actually the time it takes us to write those notes, if the AI can support us in that and take a bit of the time away, we still have to read it and make sure they're correct. But it can help us, and there's lots of areas of that.
Claire, I fully agree. We need to leverage these technology advances. Hence, the aspirations from my studies really to raise the platform of nurses' voices and also practitioner adopting this advanced technology. Especially now we are talking about how we reimagine nursing in the next decade, and it is our platform. It is key that we are going to work collaboratively through multi-professional approach to bring the technologies to the next level to enhance the patient care. Yeah.
Great, thank you. And that actually brings me on to my next question for you, Lian. Actually, when you talked about multi-professional just there and the fact that we need to reimagine nursing, absolutely, and make sure we're at the forefront and be in that discussions. But we do work in a multi-professional environment, don't we? And this is from Jackie, and she has confirmed it is the Jackie Hunt. So welcome, hello Jackie, nice to see you or not see you. But she asked us, what did the surgeons think about your findings? Have you shared those with them? Because they are amazing, the findings that you did.
So my thesis, I'm getting the paper to be published, but nonetheless, I have my integrative literature review. And very interesting, it actually has brought to attentions of our medics, clinicians, surgeons. I had feedback, and they found that's very interesting, and they were seeking collaborations. They wanted to collaborate and to get a better understanding because this subject matter hasn't been brought about, especially from our voices, from the perspective of nurses. Don't forget, one surgeon needs so many number of practitioners to assist, and without practitioner next to it, the robotic surgery will not be proceeded as what we are seeing currently. Hence, the nurse's voice, especially from my research finding, the dynamic has changed. The surgeon away from the patients, and now the full control is not the robot, it's actually the surgeon controlling the robotic arm, but the full control from the soft skill and the technical aspect and also controlling the whole environment will be solely relying on a experienced practitioner. Experienced practitioners, not just about technical experience, is one of whom will be able to navigate around the environment with a good relationship with the surgeon and the team. Yeah.
Lovely, thank you. I don't think we've got any more questions in the chat. We have got a few more minutes, so if anybody else got any more, but I've got one for both of you actually. So you've both alluded to the key of expertise, the influence that that's had on that relationship, that communication. You also both talked about overload and people having to make a choice sometimes about what they do. So, for example, you, Carol, talked about the people focused on getting the notes done, and rather than combining that with the combining that with developing that therapeutic relationship, so that getting into place. And Lian, you talked again around about the fact that that moving people away, and how that relationship. So do you think as technology becomes the norm, and it is seen in everyday practice more and more and more, um, 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 do you think future nurses will be better able or equipped to manage these complex communication situations that we're talking about, whether that be in surgery or at the patient bedside? Or do we need to think differently how we educate the future workforce, or as expert practitioners actually role model what we're doing and explain how we are managing to do these things that others aren't? So, Carol, that's quite a long question. Do you want to start first of all, and then we'll move on to Lian?
Yeah, so I think education is key really to it all, isn't it? It's I think it's really difficult if you haven't used the systems before and you are going to focus on them because they relate to physical care quite often, or compliance. You've got to a lot of the stuff on EPR now for nurses, it didn't used to be as much stuff. It's everything now, care plans, anything to do with the patient, is on the EPR. It was on the EPR in the trusts where I conducted the research. And increasing awareness starts from students. So with all healthcare professionals really in pre-reg programs, sort of highlighting the importance of being of having that communication, the face-to-face and open communication. And it's sort of, I think it's education from pre-reg, preceptorship programs, when we do digital training, to sort of highlight the need that we still have to think about those communication aspects of care and person-centered care. So highlighting that in education. A lot of our student proficiencies, when we look at technical competence or proficiencies, focuses on the technology and not the patient necessarily. You should explain what you're doing, etc. But I think communication skills really need to be integrated into technology training, be it pre-reg, preceptorship, or later. But there's also an aspect of digital training needs. So I know there was a recent national survey to students on their digital training, technical skills, and I can't remember what the questions were as part of that survey, but they were looking at how to meet students' needs in the future. And I think everybody comes with different backgrounds and different, if we're employing staff, some are from abroad, some international educated, they've never used an EPR system before, but their supernumerary time is exactly the same as a nurse that is from the UK. And sometimes they can really struggle with the EPR. Not all international nurses, but some can. If that's a new system, it's quite hard to navigate. And so that there is also about assessing your learning needs when you come into a trust, for example, or when we're doing training. And you can't presume that somebody that's older and more experienced is good with the technology. You might get someone that's young that's really good with technology, but it's integrating both the communication and the technology. So highlighting it in publications and having more research in those areas, because it might be different in the community with iPads. I don't know. There's no research out there at the moment that's looking at that. I don't know if I've answered the question, Claire.
No, you have. That's great. And I'm going to hand over to Lian in a minute. But first of all, I think Vishal's made a really good point in here, is that, actually we can focus on the pre-reg, but actually, technology is going to continuously be changing, as in the fields of engineering. And Lian studied the prime example of that. I loved your little picture of, how it's changed in the operating theatre, and that's the same everywhere. So actually, we do need to as nurses and healthcare professional, realize that things are going to change quickly now. I think quicker than ever, those of us, yes, and then Helen's just put in a response as well, again, about continuously in the field, yeah, and a major role in the future will be nurses to adapt. So as we need to be adaptable. So Lian, what are your thoughts on that?
Yeah, thanks for the questions, Claire. I felt that we are actually positions in an advantage situations, and also we are currently working, I think majority of us, we are working in the environments that we have at least 3, 4 generations, and we need to tap onto this opportunity. We have the younger generations who have got amazing technologies, ability. They are the mentor for the experienced practitioner who have got the skills and the prior knowledge, and also all the prior experiences they could share. So there's this reverse mentoring culture that we need to promote. But at the same time, as Carol, you mentioned about the diverse workforce that we have, and I'm not referring to the international educated nurses. I'm referring to the workforce movement across the world, and we have colleagues who might come from countries that they haven't got the opportunity exposing to this advanced technology, but coming to a new environment, new system that rapidly changing with the advances in technology, will be the EPR or will be the robotic surgery or any other advanced technology in applications as part of the tools to achieve the best care for the patients, and hence educations at all level, not just undergraduate and postgraduate, but I would like to say that the educations it's shifting. It's no longer education in the universities and come out and then you could immediately apply to what you studies in practice. And even though in robotic world, nurses who work in the operating room with years and years of experience, a lot of them, they wouldn't want to come into robotic theaters because they found, oh my God, this is additional kids. I'm not going to touch that. There is additional things that I need to worry about. However, they are younger one. They are actually looking for us to come to work in robotic or because they really want to use the gadget. So we have a dynamics group. It's no longer you teach one, you do one, and you observe one. No longer such thing. Now, simulation is very much on multi-professional approach. But nonetheless, I also like to highlight that the education system will be in academy or in the hospital setting or in a collaborative role. We need to look at how can we bridge the technical and non-technical aspect. I'm not talking about the non-technical from the safety WHO non-technical. We are now talking about relational communications. It's no longer one-to-one communications or two-to-one communications. It's not about I say something to you, you feedback. Yes, in robotic surgery, we have this so-called feedback loop communications. Surgeon will say something and the nurse at the bedside or assistant will repeat before confirming any actions. However, my study found that there are more than that, not just about feedback loop. There are a lot of communications that unexplained, communications that learned, communications that through pattern recognitions, and also intuitions. Hence, the AI technology is one of which pattern recognitions and AI generative intelligence, it will come. But we will be the one who will need to tap on our intelligence to drive the AI technology in the future. And collaborations in the university with the multi-faculty setting together with the clinicians in practice will be the key for the future.
Lovely, thank you. And another final question for you, Leanne. Luke has asked, if an older person or anybody who's probably maybe not even just an older person was having robotic surgery, they might be actually terrified of that machine. It is big, isn't it? They are big. They look big. What do nurses actually do to help the patients feel safe and relieved from that?
Yeah. So this is Thanks for the questions. And that's the next phase, which my research has found that patient engagement will be key for the next step of the research. In the previous setting I worked with, we did introduce the surgical robot to the patients, shown the patients what's that tools look like, what's that surgical robots looks like, and give the patients a reassurance. But now I come back to fundamental of care, Claire, as you have emphasized so much. Patient involvement, the quality of care, but now with the added surgical robot as part of the care delivery for the patients, it ought to be integral in our practice and to have the patient's engagement and the patient feedback. Patient will give us their experience post-robotic surgery that will enhance our fundamental of care in the future.
Great, thank you very much. There's no more questions in the chat, and we're just 5 minutes away from the end. So I think this is a great time for us to just sum up and have some closing remarks. And thank you both again for sharing this really important work. Before I hand over to Helen to close, I think for me, something that you've both concluded with is that for the next steps for you, it's really thinking about that patient involvement and getting their experience, their views, their perspectives on these new technologies to help us really think about how we can continue, as you say, to ensure that our fundamental needs are developed, and as Helen says, I mean, as Carol, you said, many patients are just pleased that they get the care, but actually they shouldn't just be pleased because they get the care and they disappear or they get the right surgery. Their experience should be one of exceptional person-centered care. So I think that was my closing remarks that I encourage you both to do, is to really go back now and think about that patient's experience so that we can and do those. So I'm going to hand over to Helen to close this webinar.
Oh, thank you very much, Claire, and thank you so much, Lian and Carol, for sharing your work. And what really comes across to me when listening to the both of you is how the practical nature of both of your projects and how they are feeding back into the work of the trusts. And, that is just sort of ideal for study at this level, isn't it? And thank you so much for showcasing that, and also for showing that the work that can come from this. So best of luck to the both of you in developing the ideas that come from those projects as well, and maybe we'll have you back in the future to talk about how that has gone. So we'll look forward to that as well. And thank you everybody for attending and the questions, and thank you again to Claire. So good afternoon to everybody.
Thank you.
Thank you.
Thank you.